the topic. Yeah.
Shall we start, sir?
Yeah. Okay, go ahead. Sorry.
Good evening, everybody. I am Dr. Surya Prakash, Honorary Secretary of Association of Southern Urologists. I welcome you all for this ASU webinar. Now I request President of Association of Southern Urologists, Dr. Avudiyappan sir, to address the audience and start the program.
Thank you, Surya. Dear friends and members of Association of Southern Urologists, good evening to all. It's my pleasure to welcome you all for this webinar. My warm welcome to the speaker of the day, Dr. Ashley Cox, MSMD, Associate Professor of Urology from Canada. I welcome the moderator of this session on sacral neuromodulation, benefits and beyond, Professor Dr. Sanjay Sinha, urologist and transplant surgeon at Apollo Hospital, Hyderabad. This webinar is arranged as part of the ongoing series of ASU Smart Class. We have covered so far 2 months of program on andrology and infertility. It is a program every other week or fortnightly we conduct that. And so far we have crossed nearly around 4 to 6 classes have been over. All the lectures have been recorded and has been uploaded to the YouTube channel of ASU. So the people can watch the videos on YouTube channel of ASU at their leisure hours. With these few words, I ask the Secretary of Association of Southern Urologists, Dr. Surya Prakash, to introduce the moderator and proceed with the program. Thank you all.
Thank you, sir. So, well, ladies and gentlemen, we are delighted to present to you Dr. Ashley Cox, who has got the vast experience in the field of sacral neuromodulation. Actually, I met Dr. Cox at SIU Montreal, where in one of the sessions I was presenting a talk, and Dr. Cox was chairing the session. So during the interaction, I was really surprised and impressed by the work she was doing on neuromodulation. On behalf of Association of Southern Urologists, I thank Dr. Cox for accepting the invitation to join us on this platform to deliver a talk on sacral neuromodulation. To moderate this session, we have Dr. Sanjay Sinha, senior urologist. Dr. Sinha doesn't need any introduction for this audience, but it is customary to introduce the moderator for this audience. Dr. Sanjay Sinha is the honorary professor and urologist at Apollo Hospitals, Hyderabad, and has been in practice for the last 26 years. He has got special interest in lower urinary tract dysfunction, urinary incontinence, prostate diseases, and neurogenic bladder. He runs India's busiest video urodynamic center and has one of the largest experience with stress urinary incontinence surgery. He is the South Asia regional editor for SIU Journal and associate editor for voiding dysfunction section of BMC Urology, and is on the editorial board of Indian Journal of Urology, International Urogynecology Journal, and current bladder dysfunction reports. He is the chair for the Urological Society of India Guidelines on Urinary Incontinence, and is a contributor for the 7th International Consultation on Incontinence. He is a member of International Continence Society Standardization Document Panel on Pressure Flow Studies. Thank you, sir, for accepting to be a moderator for this session. Now I request Dr. Sinha to moderate the session and introduce today's speaker, Dr. Ashley Cox, to the audience.
Thank you so much, Surya, for those kind words and a most generous introduction. It's wonderful to be here for this program and to have somebody as accomplished as Professor Ashley Cox, who is joining us from Canada. Professor Cox is Associate Professor at the Dalhousie University in Nova Scotia in Canada. She's a urologist and she has a fellowship in reconstructive and female urology. And more importantly, at least to me, she also has a master's in clinical epidemiology, and that I think is a superb combination that a clinician can have, because I think it really puts you in a phenomenal place to be able to evaluate what you're doing and to present it in the right way, I think, to the audience. She has trained with Dr. Jerzy Gajerski and has learned, as she herself told me a few minutes ago, her sacral neuromodulation technique from him. And she is currently the sole urologist who is licensed to place the sacral neuromodulation implant across 4 different states in Canada. And I really wish I was in her shoes for that. I also wear another hat today, and that hat is the National Chair of the Functional and Female Urology section of the Urological Society of India. And I think especially for those of you who are joining this program, in case some of you are not members of the section, then really you should be, because if you do have an interest in sacral neuromodulation, then the right place for you to be is with the Functional and Female Urology section of India. So those of you who are not members, I do invite you to come and join the section so that you can do more such activities through the section as well. With these few words, I think I will now hand over the session to Professor Ashley Cox. The way we have structured this is that she will give her talk for about 40 or 45 minutes, and then we have another half an hour or so of interaction time. And I do hope that you will send in as many questions as you can so that we can try and fit in and discuss as much as we can, because the more we interact, I think the more interesting the session will become and more useful for everyone. Professor Ashley Cox.
Thank you very much for that introduction. And I'll just bring up my presentation now. And perfect. Okay, so hopefully everybody can see that. Welcome, everyone. I really appreciate this invitation. This is a huge honor for me. As mentioned, I'm Ashley Cox, and I'm a urologist in Canada. I actually have no disclosures for this talk. I do speak a lot about the Medtronic product, but I am not receiving any funding for this talk today. So how did this talk come to be? Already, I think Dr. Surya Prakash and Dr. Sinha have mentioned that I did have the opportunity to complete my fellowship in female and functional urology. I've been doing sacral neuromodulation for over a decade now, and have learned this technique from Dr. Jerzy Gajewski, whose name will come up a few times during this talk. I met Dr. Surya Prakash at the SIU in Montreal, amongst other Indian urologists. And we had a great conversation and a great meeting. Of note, we did strike a common ground. So my in-laws are from Chennai. I have been honored to travel to India back in 2009. This is our wedding photos. And my little guys, who are now a few years older than that, with their cousins. So this was really a really exciting opportunity for me. So I work on the very east coast of Canada, in Halifax, Nova Scotia, at Dalhousie University, although I am from Toronto originally. And Dr. Jerzy Gajewski has been my mentor for a very long time now, and taught me initially how to do sacral neuromodulation. So tonight, what I'd like to talk to you about is just a bit about the background of sacral neuromodulation, some of the early data, the indications for sacral neuromodulation, and the data behind those indications, and try to focus mainly on the actual surgical technique, and talk about some of the post-operative considerations. And again, if I go over something quickly, then hopefully we'll have lots of time at the end to interact and do questions. So sacral neuromodulation is a technique that electrically stimulates a sacral spinal nerve root to modulate a neural pathway with the aim of treating bladder and bowel dysfunction. And we've had this technology since about the 80s, when it was discovered by Dr. Tanago and Schmidt, who found neural stimulation for control of voiding dysfunction in a small group of patients with neuropathic voiding disorders. And it was found that continuous stimulation of the S3 nerve root modulates detrusor and sphincter function and helps to stabilize micturition reflexes. And these impulses are delivered via an implantable neurostimulator. The mechanism of action, still 20 years later, we don't completely understand it. Some people do consider it more of a modulatory signal, perhaps altering a set point for voiding signals analogous to a thermostat. Or perhaps it's an override signal, where it produces afferent signals that override an aberrant neural activity that causes voiding dysfunction, or OAB, analogous to noise-canceling headphones. And I really like this study. This shows real-time changes in brain activity during sacral neuromodulation. And they took about 13 patients who had had success with sacral neuromodulation and had implanted devices. And they set their amplitude at 3 different settings. And they found an amplitude response relationship in terms of brain activity in functional MRI. So it helped to confirm that sacral neuromodulation is actually doing something with central neural pathways as well. Unfortunately, they only had 6 of the 13 patients go through all of the MRIs, but still very interesting data. And I think that there are various potential SNM effects on neural circuits related to urinary control, including effects at the periaqueductal gray matter, the pontine micturition center, and the prefrontal cortex. I think it's a very complicated pathway that we are yet to understand and have lots to learn in that regard. So in terms of FDA approval, neuromodulation is approved for the use of urgency urinary incontinence, or OAB-WET. In 1909, it was approved for non-obstructive urinary retention, urgency frequency syndrome, and by 2011, it was also approved for fecal incontinence. And of course, there are several off-label uses, including bladder pain syndrome / interstitial cystitis, chronic constipation, and neurogenic bladder. So just to go back to the early days of this technology, this is one of the main studies that was completed. It started in 1993. You'll notice that, again, Dr. Gajewski was one of the authors in this group. This was a multinational prospective study to evaluate InterStim with the original non-tined lead. So not exactly the technology that we use today. And they had 581 patients with a variety of different indications. These patients were quite severe, who had failed multiple medical and surgical interventions. They found success for 3 years post-implant for the urgency incontinence episodes. About 46% of patients were dry. In 2 years after implants for OAB patients, over 50% reported a greater than 50% reduction in voids per day. And for patients with non-obstructive urinary retention, 70% reported a greater than 50% reduction in reported volumes per catheterization. So improvement in their ability to void spontaneously. And they did notice a high surgical revision rate of up to 33%. However, patients seemed to remain satisfied. And other studies continued to support its use. This randomized trial from the same group, they're looking at the patients with urgency frequency symptoms, and there was about 51 patients who were randomized to early stimulation versus control, and 56% of patients versus 4% in the control group reported a significant reduction in their urgency frequency symptoms, and half of those in the control group elected to cross over to the implant group by 6 months. Similarly, for patients with refractory urgency urinary incontinence, very many, so 77% versus 8% in the delayed group reported a reduction in the delay of incontinence episodes with 0 heavy incontinence episodes, and the severity of incontinence improved as well for those patients who had the implant versus the delayed implant. This is another European study that also reported an improvement in the urinary factors, but also an improvement in urodynamic parameters for patients with urgency incontinence, and improvement in some quality of life domains. Adverse events were recorded here, including pain at the implant site in 32% of people. So this is a good technique that seems to be giving us good results, but we do have to be mindful of some of these adverse events, which I'll continue to talk about. So now 20 years has gone by, and a lot of data has accumulated to support the use of this technology. Certainly, for the interest of time, I can't go through every single study out there, but I would like to present some more evidence looking at refractory overactive bladder, urge incontinence, retention, and fecal incontinence. So for overactive bladder and urgency urinary incontinence, I'm sure you may be familiar with the INSIGHT trial from 2000, which was published in about 2015. It started earlier on, and they aimed to report effects for 5 years. And this was a prospective multi-center FDA mandated post-approval study, which actually evaluated the more novel quadrupolar tined lead with the InterStim device. And they looked at patients who had sacral neuromodulation versus standard medical therapy, but who had less severe symptoms. So these were patients who had greater or equal to 2 incontinence episodes over a 3-day voiding diary, or greater than or equal to 8 voids in a day. And they also found significant improvement. So they defined success as greater than 50% improvement in the average leaks per day or voids per day from baseline. And 61% of the neuromodulation group versus 42% of the standard medical therapy group reported a success. This was statistically significant, and they also found an improvement of quality of life. Interestingly, I don't believe standard medical therapy included beta-3 agonists. I think it was just anticholinergics, but still important to note the difference. When they looked at adverse events, it did occur in 30% of patients, most commonly undesirable change in stimulation, pain at the implant site, and in about 3%, they did note implant site infection, and I'm going to speak to that later on in the presentation. For those who had to have a reintervention, some of them were because of pain over the device, loss or lack of efficacy, and also infection. I think one of the most pivotal trials for looking at treatment of patients with refractory urgency urinary incontinence is one that we're probably all familiar with, and that is the Rosetta trial. So this was the refractory overactive bladder trial looking at sacral neuromodulation versus Botox in female patients, multi-center open-labeled RCT in JAMA from 2016. And they, as you probably know, they did randomize Botox at 200 units, which is certainly not what we would use for standard of care now, versus sacral neuromodulation. And their primary outcome was the number of daily urge incontinence episodes. An initial follow-up at 6 months reported that if you looked at things statistically significantly, it was actually Botox that was slightly better for a reduction in urgency incontinence episodes, but that was negative 3.9 versus negative 3.3 urge incontinence episodes a day. And I would argue that that is not generally clinically significant. So this shows that for severe patients, both Botox and sacral neuromodulation would be reasonable options for management, and I think with quite encouraging results. Over the course of 2-year outcomes, these patients were allowed to have up to 2 more Botox injections, and they had longer term follow-up for about 87% of patients. And it showed at that point no difference in decrease of episodes of urgency incontinence, and both still very effective, cutting back on urgency incontinence episodes by still 3 to 4 times per day. Botox seemed to have higher satisfaction rates, but of course, increased risk of UTI and increased risk of self-catheterization, and revision rates for the sacral neuromodulation device went up to 9% by 2 years. We were chatting at the beginning before we started the presentation about the cost of sacral neuromodulation. And I live in Canada where it's a completely public system. There is no private option here in Canada. So cost is very important, and it is a huge limiting factor for Canadians to be able to deliver this care. And this, when they looked at cost effectiveness from the Rosetta trial, they used US dollars from 2018. And you can see certainly higher when you look at sacral neuromodulation versus Botox. However, I believe there are some other studies that do show sacral neuromodulation is cost effective compared to Botox and oral therapy if you actually follow patients for 5 to 10 years. And I think, of course, it depends on what kind of cost is associated here. Even when I talk to my patients, certainly the cost that it saves them in pads alone or their ability to go back to work are completely important factors to consider. So long-term success, it has been established to be quite good. So from the Rosetta data, when they follow patients for 3 years, 59% are still reporting a greater than 50% reduction in urge incontinence episodes, and 46% being completely dry. That's life-altering for patients. And in my practice, I don't really see that with oral therapy. And single-center data, this was actually from our center about 10 years ago. And we were showing at that point 85% success, but a 39% revision rate due to lack of efficacy, pain, and bowel dysfunction. So always have to keep that in the back of our minds. And then this was our most updated publication looking at long-term success. So up to 23-year experience. And what I find so interesting is that some of this actually includes those patients from those original trials from 2000. I can see with their large scars on their back now where they actually had to have the original device where you had to dissect down to the periosteum to implant the device before the tined lead. And so what we found with long-term outcomes We had 434 patients who had had a PNE and 241 who had had the implant. So the PNE being the test phase, of course. Median follow-up was 4 years, but up to 20.5 years. And of all patients, we found that 60%, or that we found that they were on average reporting a 60% improvement in their symptoms. So my one thing we like to ask when they come back is, if you had to tell me how much better you are, what percentage would you use? And it's kind of a nice subjective / objective way to monitor their outcomes. But by this long follow-up, some had even a up to 70% form of surgical reintervention, of course, including the fact that some batteries are needing to be changed, certainly by this point. And I don't want to only focus on InterStim, because of course there is another option. I would say that I don't have personal experience using the Axonics rechargeable sacral neuromodulation system, but there is seeming to be some data that supports good success up to 2 years, with 37% remaining dry, and daily urgency incontinence episodes going from 5.6 down to 1. So again, quite severe patient population, and it does seem to be another option for patients. So of course, as you know, the sacral neuromodulation has made it to our guidelines for urgency incontinence and overactive bladder. For the European guidelines, it's recommended that this be offered to patients who have symptoms that are refractory to anticholinergic therapy based on strong evidence that I've gone through today. For the Canadian guidelines, it's recommended that physicians and patients consider it as a third-line treatment, but only for patients really who are surgical candidates and refractory to other preferred treatment options. And the American guidelines as well support it as a third-line therapy in patients who are willing to undergo a surgical therapy. So moving on to the next indication of idiopathic urinary retention, I think this is an extremely challenging thing to treat, certainly for me as a female functional urologist. It's a very complex thing when it happens to young people, particularly women. And there has been success shown for idiopathic non-obstructive urinary retention, women with retention post-hysterectomy, and of course, Fowler syndrome. As I mentioned from the early studies, 70% of people reported a greater than 50% reduction in volume per catheterization. Jonas et al. Showing a 38% success rate for the test phase, which I would say is probably a little bit lower than for what we see for urge incontinence. But for those who did have the final implant, almost 70% were able to stop intermittent catheterization with 70% success at 18 months. And some data does show decreased post-void residual, increased voided volume, and certainly an improvement to quality of life. And it is a very, very satisfying thing as a urologist to see those people get off their catheters. If there is abnormal EMG activity on urodynamics, that seems to be a positive predictor value for the success of sacral neuromodulator in female urinary retention. And some data, new data, to suggest that it is also beneficial for men with detrusor underactivity. I think those cases are a little bit more challenging from what I've seen clinically. So fecal incontinence. I fully will say that I am a technician when it comes to fecal incontinence. I am not an expert. I work very closely with my urogyne colleagues who work up these patients and send them along to me if they feel that this is a valuable technique to try. Initial trials, I guess, started in 1995, showing improved sensation, improved anal sphincter function, rectal motility with central nervous system effects. And it should be indicated for those who have failed conservative therapies like dietary changes, pelvic floor physiotherapy. And interestingly, there may be benefit with and without anal sphincter injury. The endoanal ultrasound appears to be the gold standard for evaluation. And it's thought to be fairly ineffective if patients actually have rectal intussusception. And again, where I don't consider myself an expert in these fields, I do value the input of my urogyne and gastroenterology colleagues. Off-label use of bladder pain syndrome / interstitial cystitis. I think at my center, we are known for actually implanting more patients with this condition. It's a very heterogeneous population. It's very difficult to study. Looking at our data from 2011, of this population, 78 had diagnosis consistent with bladder pain syndrome. And for those patients, there was a 73% success rate with median follow-up of 50 months. I do find a lot of these patients have urgency and frequency in addition to urgency incontinence. They're also more challenging to treat with Botox because of, I'm concerned about their ability to self-catheterize because of pain. So sacral neuromodulation is interesting to have to offer them. This is a very recent systematic review and meta-analysis that looked at 26 studies of 853 patients with chronic pelvic pain, including men. They had an implantation rate after the test phase of 64% and fairly good long-term follow-up. And when they looked at all of the studies that had different ways of measuring pain reduction, they had a weighted mean difference of negative 4.64. And I think if you look at the forest plot, you can see that the majority of studies favored sacral neuromodulation for pain reduction. And I think, again, this is a heterogeneous pain population, which is challenging to treat. It is in our Canadian guidelines. We're actually in the process of redoing these guidelines currently. We do acknowledge that it's based on level 3 evidence. Therapy is costly and certainly not widely available in Canada, and patients need to be very much counseled on the potential side effects. Same thing with the American guidelines as well. So I'm going to move forward to talk a little bit more about the actual surgical procedure now. I'm going to talk a little bit about the anatomy that we need to be aware of, some equipment and devices, and then go through the peripheral nerve evaluation or the trial phase, the final implant, and talk a little bit about the option of doing a staged approach as opposed to a peripheral nerve evaluation. So this is certainly not the anatomy I memorized when I was a resident. I think urologists, it's interesting to get used to a bit of different anatomy. So looking at the bony anatomy of the sacrum, what I'm interested in for sacral neuromodulation is the dorsal sacral foramina. And you can see that here. And from a lateral image, the sacral foramen is here. We also may use the hillock as an identifier radiographically for landmarking where to put our needles. I think a lot of people do this differently. So I would acknowledge that there are multiple different ways to do sacral neuromodulation and landmarking. Looking at x-rays here, you can see the sacral foramina here, 1, 2, I would say that 3 is in here, usually in a line with the sciatic notch. And again, looking for the region of S3, S4 on a lateral image. Nowadays, whenever I see an x-ray, I'll look at a KUB for a stone and all I look at is the sacrum. It stands out in my mind now. This is just from Netter's anatomy, again, looking at S3, and I want you to appreciate the direction of the nerve fibers. And when you compare that to radiographic imaging, you can see how we're aiming to have the electrode come from the superior medial aspect of the foramina and flare out laterally, just so you can get the electrode in contact with those nerves as closely as possible. When you look at the actual nerves and the sensory function here, S2 to S3 has the posterior femoral cutaneous nerve, so that provides sensation to the scrotum and the perineum. And the posterior thigh, pudendal nerve, of course, is the perineum, scrotum, and penis, and also the motor fibers to the levator ani, where we look for the bellows response or the uppulling of the pelvic floor, which I'll talk about shortly during the actual procedure. This is another picture just showing the parasympathetic nerve fibers and their relationship to the S3 nerve roots here. So moving on to the actual surgical procedure. So I think we all know patient selection for any operation that we do is imperative. These patients have had a detailed history, physical examination, including pelvic exam, urine studies, voiding diaries, quality of life questionnaires. And I would say almost all patients, basically all patients would have had a cystoscopy and urodynamic study at some point along the way. Most patients who, by the time they have sacral neuromodulation, they've had symptoms, sometimes upwards of 8 to 10 years, generally have been seen by multiple urologists and failed multiple therapies. So these things have been done along the way. None of these things, however, are predictive of who's going to be successful with the final implant. So having a trial phase whether it's a peripheral nerve evaluation or a staged approach with implantation of the tined lead, is the most predictive thing or predictive tool for knowing who will have success when you actually implant the battery, which again is quite costly. So I'll move on to talk now about the peripheral nerve evaluation. So some of the equipment that you need include the basic evaluation system. These are our needles here. They've actually been upgraded. And if you see the Medtronic ones now, at least in Canada, they're pink and they're actually a little bit bigger. The temporary lead, which is here, a monopolar lead, which has no tines. It's not designed for long-term therapy. I describe this to my patients as a metal piece of dental floss, and just so they can appreciate how small it is. Here is the external neurostimulator and the programmer. I bring my patients to clinic. I do this under fluoroscopic guidance. The patient is prone, which can be a challenge in itself to get the patients into that position, especially my older patients. They are prepped and draped. And I use bony landmarking in addition to fluoroscopy to try to identify the S3 foramina. And I do that before I put my local anesthetic in. Once I'm happy with my spot, I put in, I use usually about 10 cc's of 1% lidocaine or xylocaine, and I pass my needle. Usually I go straight down to the bone at 90 degrees and then work my way to a 60-degree angle to try to enter into the foramina at about that degree. Again, you can appreciate we're trying to get this as close to the angle of the nerve as possible. It can be done with ultrasound as well, but I've learned that technique, but I've never actually done that clinically. When you're passing your needle, you're aiming to have a straight kind of parallel to the midline and right at the medial aspect of the foramina. I like this picture because it shows one needle straight up and down and one needle kind of going off lateral. And this was the successful one for getting this sensation. Once I have the needle in what I believe to be the S3 foramina, we use our electrode to stimulate the needle and ask the patient at the same time, can you feel the stimulation? Where do you feel it? And that's difficult because if you have to poke around enough times, the patients just want you to stop. So sometimes I find that they do say you can feel it anyway. But in the odd case, when it is really smooth and really quick, it's fascinating how when you touch the needle, yes, it's there, and then it's gone. I do a lateral x-ray to confirm the location of the tined lead. I'll show you a picture in a moment. These patients, I secure it to their back after the needle is removed. At my center, they do wear the lead for about 7 days, and they do a voiding diary before and after. And I'm ideally looking for a greater than 50% improvement in their urgency frequency or episodes of urgency incontinence. For my patients with retention, I'm looking to see if I'd get them to do a Euroflow before and after and bring a voiding diary of their catheterized volumes. In some centers, they'll do bilateral stimulation and put 2 temporary wires in just to minimize the chance of a false negative result, because of course these non-tined leads can move around and dislodge. So this is not a very good image. I will attest to that, but you can see just where the temporary lead is going through. All of this is on the external surface here. And this is another one. I don't know if you can see that, but that helps to speak to the quality of our fluoroscopy in our cysto room. Body habitus is definitely an issue as well. So as I mentioned, when you're doing the peripheral nerve evaluation or even your staged approach, the clinic effect measured is going to be dependent on the indication for the procedure. When we're doing this for patients with pelvic pain or bladder pain syndrome, I do find it very subjective and challenging to know if they've truly had an improvement in their pain. Our patients do return 7 to 10 days later for removal of their device. Sometimes if I have a patient with fecal incontinence, I do find that it requires a little bit of a longer trial phase, depending on how frequent they're having episodes of fecal incontinence, because you want to be able to really tell if it made a difference. With the peripheral nerve evaluation, I do struggle because you may have a false negative test versus placebo effect, or patients saying, yes, it made it much better when it really didn't. I always ask the patients if they felt the stimulation throughout that week and where they felt the stimulation. Success has been shown in multiple studies to vary somewhere between 44 and 56%. And I would say sometimes higher, depending on the patients that you've selected for the procedure and your comfort level with the procedure itself. I would caution people for a peripheral nerve evaluation. Pediatric population is probably not going to tolerate this under local anesthetic. Patients with neurogenic lower urinary tract dysfunction, there's several issues about that patient population, but may not have the sensation to say if this is beneficial. Patients who are highly anxious or have a lot of pain, I estimate that there's about 1 in 10 that are unsuccessful, and I do bring for a staged approach. And some of my patients who are anxious or have a lot of pain to begin with, I'll do just a staged approach. My patients, I always tell them you cannot shower or bath for that 1 week, and that is not something they enjoy. And I do tell them to limit physical activity during that test phase. There has been this study, a non-inferiority trial, to look at patients who have this done under fluoroscopy versus not under fluoroscopy. Obviously, you can really do a lot more patients if you're not dependent on fluoroscopy. And in this study, there was no significant difference in the number of patients who underwent a final implant in those that had the test phase with an X-ray machine or without. And I think, if you're comfortable with the procedure, if your patient is open to having the procedure done, then doing it in the office is without cystoscopy suite or fluoroscopy is definitely worthwhile. I think it's very important to have nursing staff on hand to help do the teaching session with the patient afterwards, so they're comfortable taking home their external stimulator. So for those patients who do have success with the temporary lead, or for patients that you're going to bring for a staged approach, it is important to be familiar with the components of the programming system. Now, this is the older device, and I'm not sure what everybody would have access to, but up until basically last November, December of 2022, I was still using these clinician and patient programmers. So just to show you, here's a picture of the tined lead that's placed into the sacral nerve roots. The implantable neurostimulators, this is the original InterStim. InterStim 2 is what I'm currently using, although I'll show you some of the more modern products. And then the original InterStim Icon programmer, which many of my patients have and use. And then our clinician programmer, which in some ways I actually really like our older one. So this is the actual lead that we're using now, which is now the MRI SureScan lead. I just like to show this picture up top because this is the lead with the curved stylet. When you get the device, there's a straight stylet and a curved stylet for lead placement. Based on a randomized control trial, I tend to use the curved stylet. My predecessor, Dr. Gajewski, would use the straight stylet. And I think in part, I needed to do something independent in my practice to be doing something differently. So I do like to use that curved stylet. And I find it is quite helpful for directing the curve and getting more optimal lead placement. And then this is just some of the other equipment that we use. So as I was saying, the physician controller and patient programmer has now been switched over to this smart programmer, which is literally a Samsung iPhone or a Samsung phone, obviously not a Samsung iPhone. This is more costly. My hospital hasn't made any drastic changes, thank goodness. So now this is the controller as opposed to the patient icon. And this is InterStim 2. And there is also the InterStim Micro or rechargeable device, of what I don't have access to that yet, but I am interested. And I know there's more trials going on to look at the rechargeable device. So this is just to be familiar with what products are being used now. And of course, InterStim X should be coming very soon to my center. So a small device like InterStim 2, but with a longer battery life expectancy. And this is just showing the patient controller here now. I don't want to sound biased in one way or the other, so I did want to show the Axionic products as well. This is the rechargeable device. The lead is actually placed in a very similar fashion. And then, of course, the clinician programmer and rechargeable device. So let's talk a little bit more now about the actual final implant. This is the picture online that I usually show to my patients so they can understand what we are actually doing. Preoperatively, I think it's very important to discuss the risks of sacral neuromodulation to patients. I always quote implant site pain, site infection, numbness in the leg or a funny sensation down the leg, need for reprogramming or coming back multiple times to change the setting or train the patient. And also I talk a little bit about bowel dysfunction, and the fact that there's no guarantee. I also talk about positional injuries when they're prone. In terms of surgical revision rates, I usually do quote about 30% at 3 years, and I acknowledge that all patients at some point will likely require a battery change at about 5 years for InterStim 2, of course, depending on the settings that they use for their device. Lead repositioning and device explant. Infection, I find, is very, very, knock on wood, low rate. Need for MRI, if patients have the non-MRI friendly lead, that can be an issue. And I had to go into the hospital at midnight one night to actually remove a device because a patient needed an urgent MRI. So that was only happened once in my life, which was strange, a strange thing to happen. The device could malfunction, it could erode. So patients are really, it's really important that patients know that this can have risks associated with it. This is some of the equipment that we use in our OR. So these are bolsters for the prone position. We also have a radiolucent Wilson frame. We've just got this. I like this because it's for several reasons, but there is a bar across it, and I do get concerned about my patients, particularly the chest, compressing there. So very, very important to position patients carefully to avoid nerve injuries and pressure injuries. At my center, we do implant the final tined lead and battery under general anesthetic. It takes about an hour. I would say that the anesthesia and positioning takes longer than the actual procedure itself and the turnover of the room. I don't admit patients to hospital, but if they're from far away, because some of my patients come from 4, 5, 6 hours away, I do request that they stay in the city overnight as opposed to drive home. I do ask, you have to ask anesthesia. We minimize muscle paralysis beyond induction, and we minimize regional anesthesia. And certainly in some centers, in the majority of the places that I'm aware of in the States, they do this with conscious sedation and nursing anesthesia. Unfortunately, that's not what I have access to here. And I think a lot of my patients have medical comorbidities, including diabetes, obesity, sleep apnea, that a lot of those patients are not safe in the prone position with heavy sedation. I think it's really important to stop and talk about minimizing infection risk. Again, I will knock on wood to say that I have not had to explant a device because of infection, and the things that we do at our center include IV antibiotics. We use Kefsol or cefazolin. Some studies suggest that that's not ideal. For a patient, even for a patient with a penicillin allergy, we still use cefazolin. If they have a cefazolin allergy, I'll generally use clindamycin. We do a 5 to 10 minute surgical prep of the patient once they're asleep with chlorhexidine. I like to minimize the number of people in the OR. I don't like doors being opened and closed. I like the X-ray tech in the room. I try to minimize my students in there. And we use a large opsite or tegaderm to cover the skin before any incisions are made. I also have a gentamicin rinse on the back table, which is 160 milligrams of gentamicin mixed in 250 cc's of sterile water, not saline, because apparently that can have some effects with salination of the actual implant. There doesn't seem to be any data to support the use of routine postoperative oral antibiotics to go home with. Again, speaking to my patients' comorbidities and the fact that that's what I learned to do as a trainee, I generally do give patients 5 to 7 days of Keflex to go home with, recognizing that that's not evidence-based and perhaps not ideal antibiotic stewardship. I also like the patients to try to keep their dressings on for up to 48 hours if they can. And sometimes I use staples, and sometimes I close the wound with sutures, and I don't think either one makes a difference for infection risk as of yet. This is a busy OR. So this was actually a picture taken from a removal that I was doing, but I just wanted to show that there is a lot happening in the OR. You need a good space. Sterility is very important. So having a C-arm, having area for your screen that you can see. We almost have like a triangle with the nurse and myself, and I usually have a resident with me. And so it can be a very busy OR to try to organize things. And I think it's very helpful to have nursing staff that are trained on what you're doing, and that helps the flow of the case. So when you're implanting the final device, very similar to when you're doing the trial phase, you achieve percutaneous access into the S3 foramina. When I have a patient under general anesthetic, I'm looking for a motor response. The ideal motor response is going to be in the S3 nerve root, where I look for dorsiflexion of the great toe and a bellows reflux. In the OR, I understand some people will actually tape or secure the buttocks apart so they can see the anus. I don't routinely do that, but I do ensure that my plastic dressing or covering is placed lightly so that I don't lose the ability to see this movement. S4, I don't usually want just S4. It's not as effective for urgency incontinence, but if you're treating fecal incontinence, it may be more or maybe acceptable. S2, of course, that's when you actually see the full foot move or rotation of the foot. And that's more likely to result in an uncomfortable sensation for the patient post-operatively. S3, as I mentioned, so this is from the ICS statement. So it's the preferred target. We want to have ideally a threshold lower for the bellows than for the toe. And my favorite is when I can see a nice bellows reflex with a little bit of toe. And as I take the amplitude down, I like the toe to disappear before the bellows response, but I haven't noticed clinically if it's making a huge difference necessarily. So going back to the actual surgical procedure, once I have the percutaneous access and I've stimulated and seen a nice motor response, I place the guide, I pass the dilator after the needle has been removed. And yesterday I was telling myself, make sure I save an image in the OR of exactly where you want that dilator to be. And of course I forgot to save that one image. The dilator has a radio-opaque mark on it, and I aim to get that radio-opaque mark basically right in the middle of the sacrum on a lateral view. That's not actually how I was taught to initially do it. I was taught to advance it a little bit further, but by having it right in the middle, it can decrease your risk of getting false passages or having resistance when you're passing the lead into the sacral foramen. And as mentioned earlier, I use the curved stylet. Once I have my dilator and I have the track there, we pass the tined lead using the stylet with the curves. And I just wanted to show you a picture of the lead here. When you bring the dilator back, there are radio-opaque markings on that as well to indicate when your tines are deployed. And once the tines are deployed, of course, it's very difficult to move or reposition your lead. Because I don't have videos in this presentation today, I was concerned about the internet connection and that type of thing. I wanted to post these. These are excellent videos about troubleshooting and optimal lead placement. So if anyone is considering starting this technique soon or you want a refresher, please look at these. Very, very helpful and clear. They're done on Cadaver Labs, which I thought was really neat. And we talk about optimal lead placement, which certainly it refers to an appropriate motor and or sensory response at a stimulus amplitude of less than 2 volts in all 4 electrodes. And that has been shown, of course, to increase success, decrease costs, and adverse events. And if you can place your electrode so that the patient can have a lower amplitude or even subclinical amplitude, that's going to let that battery last for a longer period of time, minimizing costs in some systems, I guess, to the patient and, of course, to our healthcare system. So this is just showing optimal lead placement, appreciating the superior medial aspect of the foramina, fanning out nice and laterally as it goes down into the pathway, and about 3 of the electrodes beyond anterior to the sacrum and 1 within. Maybe even bring it back a little bit further, but that looks quite nice. Again, another example of optimal lead placement here. This is sort of the anatomy of the tined lead, just so you're familiar with it. So you have the electrodes, which are numbered 0, 1, 2, 3. your tines here, and then your connector numbers, which is what you're stimulating in the OR once you've placed the lead, to see if you can have that optimal lead placement. And they are connected, and the numbers do correspond to your electrode numbers, which also correspond to your actual IPG or battery. So for those patients, once you place your lead, you're tunneling it underneath the skin. Again, I use copious amounts of antibiotic solution throughout the procedure. Going to make a small incision in the upper buttock. Some people may choose to even look at the patient when they're sitting up or when they're in clothes and put a mark on the skin. Ideally no deeper than 2.5 centimeters and clearly above the muscle. If you're looking at this here, I'm removing this device. That's why there isn't a plastic covering on the patient here. But I just wanted to use a picture here to show exactly where it is. This was also another just nice picture of showing the ideal stimulation. And here you can see that the battery is sitting in place here. So for patients who have your peripheral nerve evaluation or your test phase and it's unsuccessful, or if it works best for your system and you have the resources to always do a staged approach, that is certainly appropriate. And a staged approach can be done with a duration of about 2 to 3 weeks. So again, at my center, I do it under general anesthetic, 2 outpatient procedures, 2 weeks apart. The first one is when I put the permanent tined lead and I tunnel it over, but instead of implanting it to the battery, we connect it to a percutaneous extension cord, which is brought out through the skin and connected to the external stimulator. With this, there is an opportunity to try different settings or programs, so it's more likely to be successful than a peripheral nerve evaluation, which could have a false negative rate. This is just a picture. I know everyone does this a little bit differently. So in this picture here, you can see where percutaneous access was achieved to the foramen. It was tunneled laterally, and then it popped out superiorly. Some people will bring it to the opposite side of where they're going to put the battery to minimize the risk of infection. And I think that's a nice way to do it as well. Anything we can do to minimize infection in this situation is important. Again, I'll knock on wood because I haven't experienced infection as of yet. I'm sure it will happen at some time. For patients that have a successful trial for those 2 weeks with the tined lead, they come back, we remove the percutaneous extension cord and place the battery. And of course, if it was unsuccessful, remove the entire device, which I know in a lot of places they do that under local anesthetic as well. So post-operative care, I just want to touch on a few different points. Programming can be challenging, particularly in older or medically complex patients. Having them understand how to use the devices can be a challenge. If I like to have nursing staff or a medical device representative around, which unfortunately at my center is not always the case, and I'm doing the programming myself a lot. If I program them immediately at the time of surgery, it's a challenge because they likely don't remember if they've had an anesthetic. It can be challenging to comprehend. And if you're in a busy OR, it's difficult to find the time on that day. But if I bring them back a few weeks later, of course, traveling and taking up that time in clinic is a challenge as well. So I think for everybody, it depends on the resources that you have. Programming there's not a lot of data about ideal ways to program. Generally, the frequency would be set at 10 to 20 hertz with a pulse width ranging between 180 and 210 microseconds, and the amplitude as low as possible. And this is an interesting recent study. My colleague, Dr. Elterman in Toronto, looked at different amplitude settings for urgency urinary incontinence patients. And they were actually able to show that even at a subsensory level, they found a fairly similar effect for control of their symptoms. And I think this is really, really important. And I love this data because it speaks to a way to minimize cost and make the device just as effective for patients and probably more comfortable. And so in terms of patient care, so they are restricted. I try to tell them to take it easy for at least 4 weeks after they've had their device implanted, and things like heavy weightlifting, downhill skiing, and horseback riding. I don't want them doing that usually ever again if they have these implants in because of the risk of fall. I see them in clinic at 2 to 4 weeks to reprogram them and check their surgical site. I think it's important that they have access to clinical care in the meantime, in case they do have signs of infection. And after the first programming, I usually have a touch point for them in about 12 weeks to ensure that they have an improvement in symptoms, their device is working, they understand how to do it. And everybody's different. Ideally, we would have annual visits for these patients. In a post-COVID world, having routine follow-up for patients who are doing well is extremely challenging. But if you have that option, I think it's great. If you are faced with infection, again, knock on wood, these are not my pictures, but if you have, this is an erosion of the actual lead, the device, and infection, most of the time explantation is going to be needed. The urgency of that will depend on how sick the patient is. IV antibiotics, irrigate and debride all dead tissue or worrisome tissue, and wait months and months until you're going to go back and re-implant them. And generally, it would be recommended to implant the IPG at a different site. I love this graph. I don't need to go through it in just the interest of time, but I would definitely refer you to this for troubleshooting. I do think with more modern techniques that we have and different ways of programming, I've even learned over the years, like things that we would have revised the device for now, I will reprogram and try different things to minimize the need for revision. Doing x-rays is very, very important. This is why I had one patient who did not have success. She lived in a different province. She actually had this happen twice. It was implanted in Toronto, and she came to me with failure, and her tissues just would not hold the tine leads. It would not heal in place. And so I do sacral x-rays on a lot of my patients. It's also good learning for me to know what happens to the device after it's implanted. I also, if you're doing a revision, highly recommend doing an x-ray beforehand, because if that lead has broke, you want to know that before you're removing it in case you have a retained product, and we can talk about that after. Of course, contraindications to sacral neuromodulation, a significant anatomic abnormality. This is an example of someone with sacral agenesis who would clearly not be a candidate. Patients who you don't think are going to understand or be compliant with the device. If they have some other issue that's causing the majority of their urinary symptoms, such as stress incontinence or a stricture, you're going to want to treat that first. Those who are not compliant, who require MRI in certain instances, and for pregnant women as well. I have implanted people who are planning to have children in the future. Obviously, we would never implant someone who's actively pregnant. We don't know the risk of electrostimulation on the fetus or the risk of miscarriage, and we always tell someone to turn their device off. So that's what I had planned to tell you today. So in conclusion, sacral neuromodulation is an appropriate therapy for many who are suffering with lower urinary tract dysfunction. There is evidence that is growing, and devices have evolved greatly over the last 20 years. A test trial, whether it's a staged approach or a peripheral nerve evaluation, is the main predictor of success. Optimal lead placement is necessary, and patient counseling and ongoing follow-up is essential for maximizing outcomes. So thank you very much for your attention. I would love to meet you and see you in Chicago next week. This is my Twitter handle for anyone who is interested in Twitter. And I'm happy to discuss and take any questions. Should I stop sharing now and we can just have a discussion?
Yes, yes.
That should be fine, yeah. Well,
Thank you.
thank you, Professor Ashley Cox. That was wonderful, a very detailed and very interesting discussion on sacral neuromodulation, very comprehensive. And I'm sure all of the people who've attended the program would have learned a lot from it. So we have some questions already there. And so let me kind of set the ball rolling with the first question which came in, and that was in relation to pediatric patients. So do you implant children, and what's your approach to children? What about younger children and so on? So your take.
Yeah, so I don't implant pediatric patients. However, but I have inherited a few young teenagers. So I had a 13 or 14, well, she was 13. She's now, I think, almost 20, 13-year-old woman who was implanted in Edmonton by one of my colleagues. I would be open to doing that. And one of our pediatric urologists is looking at getting a program going. Unfortunately, he's leaving us to go to sick kids in Toronto. But I would definitely be open to doing pediatric cases. I would touch base with my colleagues in Toronto as well before doing that. I think main thing that I would mention is I would never bring them for a PNE. I think a staged approach is best for that. Yeah, I've had 2 young women who I've had to revise when they were teenagers.
In terms of the indications, if you look at the, so okay, I can see a question here. Okay, we'll start with the questions related to the indications, and then perhaps go to the technique, and then finally go to some of the problems, right? So in terms of indications, if you look at the guidelines, for instance, the EU guideline, the EU guideline for men doesn't include the word neuromodulation at all.
Mm-hmm.
Your comments?
Okay, so I suspect that neuromodulation, and maybe I'm incorrect, I know, but I think they haven't been included in the studies as much as women have. I think probably for any study on OAB and urgency incontinence. And I think that that's being recognized more and more, that men can have primary OAB. Just because you have a prostate doesn't mean it's a prostate problem. I think that I think more data is needed on male patients with sacral neuromodulation to really support its use, but I do suspect that it will be shown to be effective. Particularly, oh, sorry, go ahead.
No, yeah. So in the male patients, one of the biggest challenges has been patients who are, let's say, post-TURP, and they don't void because they have either an acontractile or an underactive detrusor. So a couple of questions here. One, do you have any experience with such patients? And the other, do you believe that the existing classifications we have or technologies we have in making a diagnosis of acontractility, that's enough for us to be able to triage which patients will benefit and which won't? Because acontractility is again a mixed bag, ranging from patients who have detrusor failure to reflex problems to central problems and so on.
Yeah, I would agree. So I think it is, I don't think we have great ways to predict who is going to benefit from sacral neuromodulation. I think we have fairly good techniques for urodynamic studies to say if you have an acontractile or a hypocontractile bladder. And I would say that patients who have completely, in my experience, the men who have very large or acontractile bladders, that it has that large floppy appearance to it. When you do a cysto, they have a capacity of 3 liters. In my experience, those patients do not benefit from sacral neuromodulation. But I find that men who have some contractility still, and perhaps if there is a neurological cause or other cause other than obstruction, I think that they may have, in my experience, have had more success with sacral neuromodulation. But I'd be very interested to hear what your experience is as well.
Not much experience. And I actually looked up to the guidelines to get the sense of, because when I speak to people who are doing a lot like you are, I find a lot of optimism when I talk about any sort of patient subgroup. So literally nothing is working is going to work. And if you look at the data seems to suggest 60-70% success rates across the board. But I am pretty certain that if you take every patient who's a post-TURP failure and put a neuromodulation, your success rates are going to drop precipitously. So yeah. I have very little experience in that group. But I was just wondering whether it's offered to patients as, let's say, a patient has a post-TURP retention, unresolved, patient is not obstructed. Would such patients automatically be offered a neuromodulation in your setting? Or would they be offered in catheterization?
If they are referred to me, which I think there's probably a large patient population who are not even referred on. But I have the discussion with them. And if there is some sign, so the things that I consider, if there's some sign of contractility, it's hypocontractile. If they are a surgical candidate, if they are devastated by having to catheterize themselves for the rest of their life, or it really is a big issue, I'm more than happy to offer them a PNE, or in some cases, even a staged approach if the PNE is unsuccessful. Because I think, we don't know, we don't have the data. The risk is pretty low for these patients. Like if I have a 85-year-old comorbid man on blood thinners whose life expectancy is maybe 5 years, or a nursing home person, and they have a catheter, I'm not going to talk about sacral neuromodulation. But I can think of a lot of patients who I have, and I had one man who was a firefighter and working and having to catheterize. It was very devastating to his actual life. And so I offered him. It wasn't successful. But I think it's totally reasonable thing. If you have the access, I mean, it's a pretty big deal for someone to have to catheterize their entire life. It's costly too. You risk infection. So I think
So
It's,
there are
it's
several questions, perhaps we can have quick discussions on each of them. So any restriction in terms of occupation or sports in patients with implant? That's one of the questions here.
Yeah, very good question. So for sports, I say, rugby, horseback riding, downhill skiing, contact sports. I mean, it's not an absolute indication, but you could ruin the device, right? You can, if you're going to have a fall, if you're going to injure it. So I do tell those people, very cautious of that. Skiing is a big thing in Canada. And in terms of occupation, so I think the different devices, like if you have an MRI friendly device, but there are some people who work with heavy machinery and heavy mechanics. I had one patient who was a welder and worked with some big mechanical device that apparently could affect the actual electrode. So I think you have to be mindful of that. And the companies are usually really good to, if you have any concern about a patient.
What proportion of your patients need adjuvant medication?
I love this question and I want to actually study this because
Dr.
I
Nishi,
think,
yeah, Dr. Nishi asked that question in the chat box. Yeah, go ahead.
yeah. So I try to, after I do an implant, I try to take them off of everything. I have, I'd estimate maybe 5. I have a few patients now that are getting Botox and sacral neuromodulation. And I have a lot of patients who, I can't give you an exact percentage, but I actually would like to look at the data on this for my population. I would say 15 to 20%, no, maybe 10 to 15 are on medical therapy as well. And it's hard because I do have a patient population where they're older now, the battery has died, or it's less effective. I don't want to revise them. And if I can put them on mirabegron or a low dose anticholinergic, if that's effective, that's great. So if it can minimize or so I think it's important to look at that.
There's another question by Dr. Arun regarding the use of direct stimulators. So, like the Bradley kind of implant. So do you have any experience with those kind of stimulation devices?
Unfortunately, I don't. But I'd love to hear if you have experience with it,
No,
Dr. Sinha.
I don't. Right. Okay. Now there's a question regarding pain in the back. So I'm going to ask you this. Now we're venturing into the technical territory now. So in terms of the way you position the lead, where your lead number 3 is, electrode number 3 is positioned, do you think how important is that positioning in terms of pain at the local site?
Yeah, I think for pain, I don't have a lot of patients who have pain from where the lead goes into the sacrum. My patients, I find the stimulation painful. Sometimes it's too painful in the rectum, or it's uncomfortable stimulation down their leg, or it's the actual battery that they find painful. So I haven't noticed an association where my third electrode is and pain necessarily.
Now, when you're looking for the responses during the implant, now there are essentially 3 sets of responses. You're looking at the sensory responses, you're looking at responses in the bellows reflex, and you're looking for responses at the foot, at the toe. Yeah. Now, how important for you is the sequence in which you get these responses when you're increasing the stimulation?
Yeah. So ideally, I want a nice bellows and a little bit of toe. I don't like when I see the foot move. That makes me concerned. And I don't like when I don't see the toe move at all. So ideally, I'll put it at 2. And ideally, I see both. And then as I turn it down, the toe disappears and I see a little bit of bellows. That doesn't always happen. Right. If I see just toe and bellows at 2, particularly if I can get that in all 4 electrodes, I'm very, very happy.
Do you ever find it challenging, the fact that you're doing it under a general anesthetic and hence you're hampered because you don't get feedback from the patient regarding the sensory part, which probably is as perhaps, if not more important? Yeah,
I do think about that a lot. And I wish that I had an option to do both. And I do have some patients where I may start doing this more in the OR to try for like my healthy patients who aren't too obese to do it just with a bit of light sensation or light sedation, pardon me, so I can get that third component as well with the sensory.
Right. Now, in terms of looking at the bone anatomy, the challenge that happens is that, at least in India, whenever many of these women who are older, let's say in their 60s and so on, they have severe osteoporosis. And it's almost impossible to see any sacral foramen on their X-ray on the C-arm floors. Yeah. I don't know whether you face that. So it's mostly, rather than looking at the foramen themselves, it's mostly looking at the landmarks. and going ahead, with based on the landmarks, with an experience of how you're supposed to put the needle in?
For me, I would say the limitation in my patient population, the limitation is more body habitus than, because once I can usually see the foramen quite well. I can feel them, like when I get into the right spot. I don't find, I haven't noticed that osteoporosis is the biggest issue. For me, it's more body habitus. My 2 cases yesterday, one had a body habitus of a BMI of 40 and one had a BMI of 45.
Wow.
That was the one we couldn't actually proceed with the case because we couldn't ventilate or prone.
Right. And if you use some of that, sometimes, do you have any difficulty getting a needle which reaches far enough? Because sometimes the needles that are supplied, the 3.5 and a 5 and that 5-inch, the 5-inch might, I'm not sure whether that's even enough for a patient like that.
There is a longer needle. I have an obesity one. Yeah. Which maybe that is the 5 one. I haven't had any problems with those are I've been able to get it with those needles.
Right. There's a question here on what's the role of neuromodulation in patients who don't show a response on the percutaneous evaluation. So would you at that stage discuss with the patient that it's not worth it, or you try it on the other side now, or you'd anyway go ahead with an implant? What do you do?
Yeah. So my approach to a failed peripheral nerve evaluation is, one, if I was not happy with the placement of the PNE, like my needle placement, if they did not feel the stimulation in the rectovaginal area, or if I was doing a male patient in the scrotal rectal area, if they showed signs of not understanding how the device worked, I would talk to them about doing a staged approach and giving it another try. If the x-rays looked great, they felt the stimulation, the device was the actual external stimulator worked well, and their voiding diaries were just no different, I am very hesitant to offer them a staged approach at that point. I don't move forward with implanting the full implant after a failed PNE based on healthcare resources and cost.
So would your approach be different had your first step been a tined lead and then the patient had failed, vis-a-vis a patient in whom you've done the percutaneous nerve evaluation and the patient has failed?
Sorry, can you repeat that again? I think I don't understand.
Would your approach be different for a patient who failed the tined lead compared to the patient who failed the percutaneous evaluation?
Well, I guess I will, if they fail the PNE, I always have the backup of the tined lead trial. So I don't give up on patients very easily, like, because these are severe patients. Like, they've tried everything and they're miserable. And so if you fail a PNE, I am likely to offer you a staged approach with the tined lead. But if you fail a tined lead, and again, like, I'm happy with the placement, the sensation was there, and you understood how it worked, and it failed, then I don't put the device in and I remove it and have to move on to something else.
So Dr. Arun has a question regarding neglected posterior urethral valve patients who got a decompensated bladder. What do you think of implanting them?
You know what? I think those are very severe patients who, if I don't have I haven't seen a case series on that patient population, although perhaps it exists. And so I think if they, I think you'd be fine to try it, as long as, with those patients, I always worry about watching their upper tracts forever, because you never know. I mean, usually the upper tract problems are there. It's usually there, but by the time they're an adult. But I think that's a unique patient population, and sacral neuromodulation should probably be considered.
Surya had a question with regard to neurogenic dysfunction. So his question was specific for patients who have myelomeningocele, but let me broaden that question and ask you about a wide range of patients. So let's say patients who have suprapontine problems, Parkinsonism and those kind of issues. That's one set of patients. And then there are patients who have got problems which are in the spinal cord, infrapontine, let's say suprasacral or sacral. So what's the regulatory status in your country, and which patients, do you implant patients like that? And what's the situation?
Yeah, so I really don't have a limitation on who I could implant. I have done some neurogenic bladder. I have some MS patients who are ambulatory young people who have bladder dysfunction. And there are a couple of patients in our series with Parkinson's. From a neurogenic perspective, I think that you need to be concerned. I think it's a reasonable thing to do, particularly if you have the MRI compatible device. If you don't have the MRI compatible device, it can be an issue, particularly for MS patients who may require ongoing follow-up with MRIs. For patients who are in wheelchairs, I do have concern about the device being implanted in the buttocks, particularly with a risk of erosion, infection, and wounds in that area, pressure ulcers. You have to be mindful of that. For patients with spina bifida, I haven't seen great data to support that. And I think their bony anatomy, I don't have the experience, skill set, or technology to safely implant those patients as of yet. Although I do suspect neuromodulation in all neurogenic patients, probably, if we did it properly or knew how to do it, could be effective.
So let me ask a more specific question. When you're putting your neuromodulation in these patients, are you looking to improve their storage function, which is refractory, or are you looking to get a patient who's completely dependent on CIC off the catheter? Because if you look at the data which is there, most of the data is actually, if you look at most of them, the neurogenic patient population which have been there, very few studies, number one, and when they are there, they don't really give you good condition specific outcomes. So let's say if you look at a group of about, I'm forgetting the exact number, it's close to 100, which was published recently. And in that, the number of patients who actually had condition like spina bifida, spinal cord injury was small. And even there, if you look at the patients who actually had voiding problems related issues, there was even smaller. And what's the intention with which you are implanting?
So my intention for the ones that I have done or that are in our series was for the storage symptoms, for the urgency incontinence. And I think it's like, if you were, I haven't done any spinal cord patients, but I think it's really, really important to make sure that you maintain recommended screening protocols of their upper tracts, even if you have.
So I'm glad you brought that point out, because what's happening is there is a group of, I shouldn't say people who are very aggressive with the neurogenic population, and this aggressiveness stems from the patient's desperation in needing a catheter. And most of the data is actually on trying to improve refractory storage symptoms rather than getting them off the CIC. So I think it's an important point to bring out. And of course, the patients who have spinal and cord injury and myelomeningocele, that they are high-risk neurogenic dysfunction, where the focus of attention is completely different, which is on safety of the upper tracts.
And I worry about infection in my spinal cord injury patients and my spine. I have a multidisciplinary adult spina bifida clinic that we do once a month with neurosurgery and physiatry. And it's been a fascinating thing to watch these patients age. I think we have patients who are in their 50s, 60s, 70s with spina bifida, and some really serious infection complications happen. So I would be very concerned about putting a pacemaker in one of those patients, although there are patients who are totally ambulatory and high functioning. But I agree with you. I've never seen data to say, I'll put this sacral neuromodulator in you and you won't need to catheterize. It would be more about the implants.
Dr. Arun has also put in a question regarding training opportunities in Canada. So maybe if you can just give a quick answer on that. And then meanwhile, Surya, if you have any questions or anybody else has any other questions, please go ahead.
I would also like to ask Dr. Cox about the training opportunities. So if somebody is interested to learn.
So Dean Alterman and Magdi Hasuna at the Toronto Western Hospital through U of T, they have a fellowship program. Jersey, my predecessor, had a fellowship program going for externally funded students or fellows. Usually we would have fellows coming from the Middle East to train and specifically learn how to do sacral neuromodulation. He retired in 2018, 2019. I'm the residency program director, so I didn't have the opportunity to take over that fellowship at that point in time. But currently I am trying to get I actually have a gynecologist coming from Australia to work with me in July for a year. And that will be one of the main objectives. So I'm hoping to have the fellowship back up and running, but mainly I think the most established one in Canada would be in Toronto. Also at McGill University, Lisanne Campeau, you may know Lisanne Campeau. She does a lot of basic science research at McGill and overactive bladder. She's a reconstructive urologist who does sacral neuromodulation, and they have a fellow. I think it's also externally funded. I'm not sure. So McGill as well. I don't know how much of it is sacral nerves, but it is part of it. I hope that helps.
Oh, yes. Any other questions or comments from the audience?
So is Medtronic available, sir, in India? This team?
Yeah, it's available.
How much
The InterStim too. The same device which Dr. Cox is implanting.
How much does it cost, sir, in rupees?
So
I tried to look that up.
So it costs about so if I don't know whether anybody from Medtronic is here or not, roughly I think 6 or 6.5 lakhs is roughly the cost overall, I think.
Okay.
So the only thing here is that this particular device is on its way out.
Okay.
In the sense that we now have longer life devices coming in. And but one thing is there, that you can put this, and if it works well, then you can replace the battery with the newer type of battery when that one becomes available at the end of life of the first one. But as I can understand from them, the battery which lasts double the life also costs double the amount of money. So monetarily, patients don't really, as of now, don't seem to have benefit. But in terms of longevity of the device, perhaps they will. We need more competition in the market to get the cost down. It's certainly not.
Totally do. Oh my gosh.
Right.
The other thing I would say, Dr. Sinha, do you have experience using the rechargeable device?
No, it's not available to us here.
Okay, yeah, I haven't heard. My understanding is that patients don't actually like it as much as I think people expected them to. It's a bit of a pain.
People would like the longer lasting battery rather than the rechargeable, which is a nuisance actually, recharging again and again.
Totally, yeah. I'm really excited to have InterStim X. I hope we get it soon.
So I think we are coming to the end of our, we were supposed to do this in 90 minutes, Surya. We are 5 minutes short for you to close the program. I would like to really thank Professor Ashley.
I think in India, we have a large pool of patients. The awareness is not there among the patients. And even as you can see, many urologists asking for training courses. Even the urologists also need to be trained. I think that your upcoming subspecialty meeting.
So we are already planning a session, a training program. That's the discussion I was having yesterday with the guys when they asked me about this. When I told them suddenly that, okay, we've got this program, I'm sure you know about it. And he said, no. So we are planning something in our, we'll have a 3-hour workshop with dummy demonstrations and so on at the annual workshop conference. So that's planned.
That would help, sir, if you can, some dummy demonstrations.
It's already planned. So I would like to thank Professor Ashley Cox for a wonderful session. Thank you so much, and for answering all those questions in such a lucid manner. And I had now handed back to Surya, and I hope, Dr. Ashley, I'll see you perhaps at the ICS in Toronto later. Look forward to meeting you again. Bye.
Yes, you too. Thank you so much.
Thank you, sir. I profusely thank Dr. Ashley Cox for accepting the invitation. She's very prompt in her responses. The moment I give a mail, within 10 minutes, I get the response. Thank you so much. It was really very informative talk. It's a new subject for most of us. I think many people are not aware about the greatness or the real innovativeness of this field. I think this will go into the YouTube. We'll get a lot of viewers. And you may get a lot of questions in the YouTube also. I'll forward those questions to you.
Perfect. Feel free, if anyone is on Twitter, it's at Ashley Cox 1000, and I'm happy to answer questions through that as well. And this was a great honor, and I really enjoyed the opportunity.
Thank you. Thank you very much. Dr. Avurepan, sir, closing remarks. Sir, you are mute. You're muted. You have to unmute.
Oh, thank you, Surya. Thank you, Ashley Cox and Dr. Sanjay Sinha for coordinating with us on this program. And it went on very well. We had a good information on all this. And it is very happy to know that many people are interested in going for the training. I think Dr. Sanjay Sinha will take it in a bigger way and pave a pathway for the people who are really interested in SNM for a good training for program. Thank you, sir. Thank you all. Thank you for attending and thank you for listening. Thank you for the lecture and thank you for the moderator. Thank you, Surya.
Thank you. Thank you, everyone. Thank you, Dr. Cox, Dr. Sanjay Sinha. Thank you. Good night.
Thank you. Have a good night. Take care.
Thank you so much.
Good day for you.
Bye. Thank you.